Bismillah ar-Rahman ar-Rahim. Superior vena cava obstruction. It is an obstruction of the flow of the blood in the superior vena cava, results in the symptoms and signs of superior vena cava obstruction. It is caused by two different mechanisms which may coexist: external compression or invasion of the superior vena cava by tumor extending from the right lung, which 4 times more common than the left lung, lymph nodes, or other mediastinal obstruction, or due to thrombosis within the vein. The etiology, the commonest cause, about 85%, is malignancy. Lung cancer and lymphoma together cause 95% of malignant superior vena cava obstruction. Malignant causes include the following: lung cancer. Up to 4% of lung cancer patients will develop superior vena cava obstruction at some point during their disease. Up to 10% of small cell lung cancer present with superior vena cava obstruction. Lymphoma. Up to 4% of lymphoma patients will develop superior vena cava obstruction, most commonly in non-Hodgkin's lymphoma. This is usually occurs due to extrinsic compression of the superior vena cava by enlarged lymph nodes. Other malignant causes include thymoma, mediastinal germ cell tumor, tumors with mediastinal metastases, which are commonest in breast cancer. Benign causes include granulomatous disease, intrathoracic goiter, and central venous lines, port A cath, and pacemaker wires causing thrombosis. In the past, superior vena cava obstruction was commonly due to untreated infection, such as syphilitic thrombotic aortic aneurysm or fibrosing mediastinitis due to actinomycosis, TB, blastomycosis, or aspergillus. These are all now rare. The clinical picture or clinical features of superior vena cava obstruction. There are facial and upper body edema with facial plethora, often with increased neck circumference and a cyanotic appearance. Venous distension of the face and the upper body. Superior vena cava obstruction due to malignancy usually develops over days to weeks, so an adequate collateral circulation does not have time to develop. Pemberton's sign, facial plethora, distress, and sometimes stridor after lifting the arms above the head for a few minutes may suggest the diagnosis. Breathlessness also present. There is headache, which is worse on bending forwards or lying down. There is cough. There is hemoptysis and other signs of underlying lung malignancy. There is hoarse voice. There is dysphagia. There is syncope, dizziness due to reduced venous return, and there is confusion. The diagnosis, usually made clinically from the signs of facial and upper body swelling with distension of superficial veins across the chest wall, neck, and upper arms. Investigations used for confirmation of diagnosis of superior vena cava obstruction. The investigation and treatment of superior vena cava obstruction was previously considered a medical emergency. Superior vena cava obstruction is now not considered to be immediately life threatening, making treatment less urgent and allowing a definitive diagnosis to be made before treatment. The exception to this rule is the patient who presents with stridor or laryngeal edema, which is a medical emergency. The investigations include chest x ray, in which up to 85% have an abnormal chest x ray, as malignancy of the lung is the commonest underlying disorder. Mediastinal weaning, mediastinal widening is common. CT chest with contrast can stage the underlying malignancy and image the venous circulation and the collateral blood supply. Histological diagnosis. Usual practice is to obtain a tissue diagnosis of the underlying disease before starting treatment, as the underlying diagnosis can alter treatment markedly. Symptomatic obstruction will have been developing for some weeks prior to presentation, and in clinically stable patients, a delay of 24 to 48 hours while the correct underlying diagnosis is obtained is warranted. Radiotherapy before biopsy can lead to problems making a subsequent histological diagnosis, and similarly, high dose steroids can make the diagnosis of lymphoma difficult. Diagnostic samples may be obtained using pleural fluid cytology, ultrasound guided biopsy of extrathoracic lymph nodes, such as supraclavicular or cervical nodes with low risk, bronchoscopy or mediastinoscopy if no endobronchial disease may be needed, depending on CT features. There may be increased risk of bleeding post biopsy because of venous congestion, and anesthesia is theoretically riskier because of possible associated tracheal obstruction or pericardial effusion, potentially leading to hemodynamic compromise due to cardiac tamponade. Though this can be anticipated from the CT scan. Now, the management of superior vena cava obstruction. There is This is usually in two phases. Initial general treatment include oxygen, analgesia, setting the patient up to reduce venous pressure, and steroids in some cases, followed by treatment of the underlying disease causing superior vena cava obstruction dependent on the tissue diagnosis. The major differential in terms of treatment is small cell carcinoma. The treatment initially is chemotherapy, and in non-small cell carcinoma, the initial management or initial treatment is radiotherapy, and lymphoma, in which the treatment is chemotherapy. The presence of superior vena cava obstruction usually means that surgical resection of a non-small cell lung cancer is not possible. The steroids used in superior vena cava obstruction There is limited trial data to support the use of steroids in superior vena cava obstruction prior to definitive treatment. Most would start them fairly promptly, such as dexamethasone 8 mg BID, avoid in the evening as it affects the sleep. They may reduce edema and improve symptoms. Ideally, a tissue diagnosis should be obtained before commencing steroids, but may not always be possible. Use of steroids is problematic if the underlying diagnosis is lymphoma, as steroids may alter the histology, making a definitive diagnosis more difficult. In an older smoker with an obvious chest x ray mass, in whom the diagnosis is likely to be lung cancer, steroids can probably be started without risk to the underlying histology. Radiotherapy. 90% of patients are edema free by 3 to 4 weeks. In those with a poorer response to radiotherapy, only 25% survive 1 year. Intraluminal stents used for malignant superior vena cava obstruction and may be a first line treatment while radiotherapy is planned. Successful in 90% of cases with relief of symptoms in most patients within 48 hours. They do not prelude they do not preclude subsequent radiotherapy or chemotherapy. In small cell lung cancer, however, chemotherapy will improve superior vena cava obstruction rapidly, so stent insertion may not be necessary. Unclear if post-procedure anticoagulation is required. Some centers advocate the use of low-dose warfarin anticoagulation, that's to say 1 mg per day, aiming for an INR of below 1.6. Thrombosis in the superior vena cava is not a contraindication to the procedure, as clot can be dispersed mechanically or with thrombolysis at the time of the procedure. Stent complications. Stent migration is the major complication, but most patients don't live long enough for this to be a major problem. Anticoagulation used in lung cancer. Some recommend prophylactic anticoagulation in the presence of superior vena cava obstruction, a small increased risk of intracerebral bleeding, but the benefits of superior vena cava obstruction treatment may be limited by subsequent superior vena cava thrombus if anticoagulation is not started, and this is controversial. Superior vena cava obstruction due to thrombosis, usually in association with central venous lines or pacemakers wires, if the clot is below 5 days old, as judged by symptoms, thrombosis or thrombolysis is warranted, and subsequent oral anticoagulation may reduce recurrence. Prognosis of superior vena cava obstruction depends on the underlying disease and is unrelated to the duration of superior vena cava obstruction at presentation. The majority of superior vena cava obstruction is due to mediastinal spread of carcinoma of the lung, so the overall prognosis is generally poor but depends on the patient's prognosis and stage and extent of the disease and cell type. Again, the prognosis of superior vena cava obstruction depends on the underlying disease and is unrelated to the duration of the superior vena cava obstruction at presentation. The majority of superior vena cava obstruction is due to mediastinal spread of the carcinoma of the lung, so the overall prognosis is generally poor but depends on the patient's performance status. But depends on the patient's performance status, stage and extent of the disease, and the cell type.